So, welcome everybody to WoundRounds webinar on F314. Today we're going to hear about F314 from a surveyor's perspective, and we'll be learning today from our faculty member, Jamie. So Jamie comes to us with a lot of great credentials and expertise in this area today. She is on staff at WoundRounds, where she serves as an implementation specialist. Some of you may have actually worked with Jamie in getting up and running with WoundRounds. What she did before WoundRounds is what makes her so interesting for us today, because she's actually been a state surveyor. In addition to that, she's been the trainer of state surveyors. So this puts her in a really great position to explain to us from the perspective of an investigator, what are they looking for when they go into and audit facilities. So Jamie actually carries the certification of SMQT, which you can see from your screen, is an actual certification criteria for being a state surveyor. In addition to that, she, like many of you I know on the phone today, is experienced in skin wound and ostomy. And additionally, probably as many of you on the phone today as well, she has experience as being a director of nursing in a skilled nursing facility. And her background extends throughout the continuum of care from both the acute and the post-acute care sides. So that's why we're just so thrilled to have Jamie with us today. A word about me. I'm Deb Kurtz, and I'm your moderator today, and I've joined the webinar to facilitate our discussion today, and I have a background also in helping wound care companies and also helping organizations that target the post-acute space. So with that, I'd like to formally give a voice out to Jamie and ask her to take us through the agenda on what we're going to accomplish today, and ask her to formally kick off today's webinar. So Jamie Smith, can you take it away for us?
Absolutely. Thanks, Deb. Good afternoon, everybody. It's great to be with y'all today. Excuse me. Hopefully I can shed a little bit of light from my experience as a surveyor. Our agenda today is understanding the verbiage at CMS tag F314. We're going to talk about differentiating between avoidable and unavoidable pressure sores, complying with wound documentation, and the do's and don'ts of working with your surveyors. F314 states that a resident who enters a facility without a pressure sore does not develop a pressure sore unless they have comorbidities that make the development of the sore unavoidable. And also that a resident having a pressure sore receives the necessary treatment and services to promote healing, prevent infection, and prevent new sores from developing. CMS's definition of a pressure sore is any lesion or lesions caused by unrelieved pressure resulting in damage to the underlying tissue or tissues. Also, CMS notes that friction and shear are not primary causes, but are important contributing factors to the development of pressure sores. Avoidable pressure sores occur when the facility did not do all that they could to prevent or promote healing, and a pressure sore developed and or worsened. Quote, all includes, but is not limited to, completing risk assessments, skin assessments, nutritional assessments, support services, and appropriate treatments as ordered. It also includes a method of monitoring and reevaluating, quote, all to ensure the care and interventions are working, and changing up the care and or interventions that aren't working. Unavoidable pressure sores occur when the facility does, quote, all that they can and should do, but a pressure sore develops or worsens regardless. Make sure you have your documentation complete to show what you did and when, and why this area developed or isn't getting better. On hospice is not a valid reason not to do all that you are responsible for in regards to pressure sores. Next slide, please. So, when a surveyor comes into your building, whether it's on a complaint or for full book, and they are looking at pressure sores, these are a few of the overall items they are looking at. Is the pressure sore unavoidable? And are the facility's interventions and efforts to prevent and treat adequate? Just remember, pressure sores only are cited at F314. All other non-pressure deficiencies would be cited at F309, quality of care. So what is the surveyor looking at or for when they do initial tour? That's the one thing I think everybody dreads, is that initial tour. They ask a lot of questions, some surveyors more than others, but they are attempting to get an overview of the resident. Specific with wounds, are dressings in place? Are they dated? Are they initialed? What does the dressing look like? Is it intact? Is it clean and dry? Saturated? Or is it saturated but now it's drying? Are there any pressure reducing devices in place? Is the resident offloaded? Is the resident having pain during this observation? And is that pain related to the pressure sore? Is the nurse knowledgeable about the resident? And is the nurse aware of any of the resident's wounds if they have any? The observations made after initial tour, the surveyor at this point has probably completed some of the record review. So when they make additional observations, they're looking to see, are ordered and or planned interventions being implemented? And are they being implemented every shift, every day? Is the facility deviating from those ordered and or planned interventions? Are the deviations causing and or having a potential negative outcome? Is positioning effective for offloading for the existing pressure sores? Are staff minimizing any potential for friction and or shearing during transfers and or repositioning? Are pressure reducing devices being used according to the manufacturer's recommendations? For example, do mattresses with an anti-friction, anti-shear covering have sheets, draw sheets, and or incontinent pads placed on them? If so, this defeats the purpose of and the advantage of having the anti-shear covering. When the surveyor is observing actual wound care, they are verifying that the most current facility assessment matches with what they are seeing that particular day. They are looking at the characteristics of the wound itself, including the tissue types, any exudate that's present, and the moisture level of the wound. They are looking at the peri-wound. Has the wound been debrided? And if so, with what? They are observing the type of dressing that was removed. Was it what was ordered? And is the new treatment being performed as ordered? And then they're going to think, is this treatment the best treatment based on the current standards of care and practice? And then lastly, they're looking at infection control practices. Are measures being taken to prevent contamination of the pressure sore by urine and or fecal matter? The surveyor will usually observe treatments when they are routinely being performed, but they may ask that a dressing be removed and the treatment done on a wound not scheduled for treatment that day. During the wound care observation, the surveyor may ask staff to measure the wound. They may also ask about staging. This is done to elicit the amount of knowledge the nurse has of the resident and the pressure sores. Next slide. The surveyor is also looking to see that staff are asking residents about their wound pain level prior to the treatment, during the treatment, and again after the treatment is completed. The expectation is that if and or when the resident expresses pain, whether verbal or nonverbal, that the procedure is stopped and the resident's pain is addressed. A facility response of, quote, "she always cries out when we touch her," or, quote, "he's getting something for pain all the time," is not an appropriate response. And no stoppage of the treatment and pain relief measures implemented is not an appropriate action either. So now the surveyor is doing their record review. This can be done at any time during the visit. I always did my record review first. That way I knew what I should be looking at and the responses the facility staff should be giving me during interviews. But specific to pressure sores, the surveyor is looking to see that all assessments are done for the nursing facility resident. They're looking to see, has the skin risk assessment or Braden been completed? Was it on admission, weekly times 4, quarterly, annually, and with a sig change? Has the actual head-to-toe skin assessment been completed? On admission and then at least weekly? Are all skin alterations being assessed? Bruises, skin tears, surgical incisions, pressure sores, arterial venous ulcers, plaques, scars, any skin alteration? And are all assessments being completed timely for the facility type and per the facility policy, whether that's on admission with a change of condition, new skin alterations, and or routinely? When the surveyor is reviewing risk assessments, which are our Bradens, they are also looking to see if interventions have been identified. They're looking to see that those interventions are care planned and that they're also implemented as planned, and that the interventions are appropriate for present on admission and facility acquired pressure sores. The surveyor is also going to review the physician's orders, the progress notes, the physician progress notes, the wound physician progress notes, and the nurse's notes. They are going to review the pharmacy consultants and the dietary consultant's recommendations and progress notes. They are looking to verify that any recommendations and or orders have been carried out. They would also possibly find any documentation of unavoidability of the pressure sores or contributing factors for the decline of the pressure sore during the record review. When the resident has a present on admission or a facility-acquired pressure sore, the surveyor is looking for any admission documentation of the pressure sore or pressure sore date identified documentation in regards to the wound itself. They're looking for measurements, tissue types, peri-wound, undermining, and or tunneling. They are looking for history of previous pressure sores, impaired nutrition, and any immobility or illness issues that could contribute to the development of pressure sores. They are also looking at any facility efforts to help lessen, modify, or stabilize the resident's risk factors and any underlying causal factors. Additionally, the surveyor will be looking to see the weekly progress and any complications that arise. Is the pressure sore treatment being reassessed if no progression towards healing is evidenced within 2 to 4 weeks? And when the surveyor reviews the care plans, they are looking for accuracy of the plan for what they saw being done for the resident. Are support surfaces in place? Are the support surfaces the, quote, name brand as identified in the care plan? Are the support surfaces being used according to the manufacturer's recommendations? Are treatments being done as ordered, using the, quote, name brand supplies if that's what's ordered? If the facility has a treatment protocol, is it in the care plan? And if only portions of a protocol are used, is that spelled out in the care plan? Does a care plan list just the area of pressure sore, or does it list the area, size, stage, etc.? And if it does, is that information up to date? And has the care plan been reviewed and revised as appropriate with changes in the pressure sore treatment and or interventions? So let's switch gears just a bit. As you can see by the numbers, pressure sores can be a large issue for your building. Avoidable pressure sores introduce risk for the facility and or the organization. When a pressure sore occurs and litigation is involved, the burden shifts to the defense team to prove that the pressure sore was unavoidable. Litigating these cases can run into expenses exceeding 7 figures. Next slide, please. All facilities, regardless of size, whether or not you're a, quote, mom and pop or a corporation, must have a risk management program in place, and it has to work. Regardless of the name of your program, whether it's a QA, QA&A, a QAPI, whatever the name of it is, risk programs all have basic components. Identification of the risk or risk, intervention planning, documentation, education of staff and or residents and or family members, and departmental buy-in. With pinpoint accuracy, a risk management program can help facilities identify the areas of greatest weakness and vulnerability. Facilities can target those specific areas for correction, enabling them to drive down their costs. Incorporating data into risk management allows the facility to objectively monitor performance in a quantitative way. Measurable progress can then be communicated to staff in a way that demonstrates risk management is everyone's responsibility. All right, so we have our risk management program in place, and hopefully it's working. So let's talk about your pressure sore program. It's a vicious cycle. It never ends. It's day in, day out. And if you don't want a big deficiency, SQC, IJ, or litigation, then it's ongoing every single day. So every day, every shift, a nursing staff assesses every resident for risk factors. They look at skin. They provide skin care, nutrition, support surfacing, and education. So risk assessments. We all probably use Braden's. There's a couple of different ones, but Braden's are the most common. Should be done according to the facility policy. Whether your policy is on admission and then daily times 7 and then weekly, or on admission, weekly times 4, then in conjunction with the MDS schedule, or on admission and then in conjunction with the MDS schedule. Whatever your facility policy is, do the risk assessment according to your policy. If you do the risk assessment prior to when it's scheduled, that resets the schedule. So for example, if it's scheduled on admit, then weekly times 4, and the assessment is completed on admission, then again on day 5, because that's Friday and it's prior to the weekend, and we know the wound nurse isn't going to be there over the weekend to complete it on day 7, then the next assessment would be no later than day 7, then 7 days from day 5. So it resets that schedule. Once you've completed the risk assessment, don't forget to identify interventions that are appropriate, document the interventions, and then make sure you've educated your staff and implemented the appropriate interventions. Then reevaluate routinely for appropriateness and effectiveness. Skincare includes not only the pressure sore treatment, but also the daily assessment by your nursing staff, primarily your CNAs, during either bathing and or incontinence care. First-line staff should be using moisturizers and barrier creams numerous times during the day to aid in maintaining an intact skin system. Nurses should be looking at skin for residents at high risk every day. This enables you to catch those new pressure sores when they are a stage 1 or stage 2 rather than when they are unstageables. Complete a thorough skin assessment weekly. This includes capturing all skin alterations, skin tears, bruises, pressure sores, rashes, self-inflicted wounds, etc., and then routinely educate and re-educate your staff on skin care. Next slide, please. So nutrition. How important is nutrition? Certain foods, mainly proteins, are the building blocks of all tissues. If a resident is malnourished or dehydrated, are they going to heal? Or are they going to have a greater likelihood of breakdown? So implement a comprehensive nutritional program for each resident who is at risk and implement it consistently. So, how many of y'all are squirming in your seats right now? I know I'm starting to get a pressure sore myself, and I can change my position even if it's just a small shift. So think about your residents who can't shift or move themselves. Sometimes all it takes is a reminder to a resident in a wheelchair as you pass by them to bend down and whisper to them, "Shift." Or have your staff, each time they go into a resident's room, to shift them in the bed. It doesn't have to be a major production of moving, just a small shift, from a 30-degree side lying to a 45-degree side lying. Small shifts to maximize remobilization. Also, get therapy involved with recommending positioning devices. Also, don't use a written repositioning schedule unless you can adhere to it. Remember to offload, offload, offload. And whatever type of support surfaces you use, it's all about offloading. For your alert and oriented residents, a trapeze bar is a great tool to get them involved in their own repositioning. This allows them to make those small shifts themselves, and then they don't feel so dependent on your staff. You can use what you have on hand. You don't have to buy the most expensive or the latest trend in offloading devices. Let's remember, pillows work great. And make sure all those bony prominences are offloaded. So think outside the usual culprits. It's not just heels, sacrums, and trochanters. It can be an inner elbow to a rib cage. It can be knee to knee, ankle to ankle, heel to shin. The list can go on and on. Keep your resident as active and mobile as they possibly can be. This will also help reduce the risk of skin breakdown, treatment costs, man-hours for care, and product use. Educate, educate, educate. Not only your nurses, but your CNAs, your med techs, your family members, housekeeping, and dietary staff. Even non-nursing staff performing a task in a resident's room can inform the CNA or a nurse that a resident is uncomfortable, that they're restless, that they're incontinent, whatever the case may be. So reevaluate the effectiveness of your education program periodically. If it's effective, you would expect to see a decrease in pressure sore development and or a decrease in worsening of pressure sores. In your education, include what makes a resident at risk. Your staff can better understand the importance of performing a task timely and correctly if they know the rationale behind the task. It's not just because the nurse said to do it, or because they're too lazy to get up to do it, or they have too much work to do, or they say, what harm could it cause to skip that? Now I can do it later. So make sure that your staff understand the whys and what fors of why we're doing something. Include the nutritional importance and why it's so important to let the nurses know intake percentages and outputs if that's applicable. Get your residents on a toileting plan, not just a, quote, catch plan. Teach proper incontinence care and skin protection. And teach what to document and then review that documentation to reevaluate your plan and its effectiveness. So critical steps in documenting. If we didn't document it, it didn't get done or it didn't happen. We all learned this in nursing school. WoundRounds enables us to complete all of our wound documentation in one spot. So we're going to talk about the 8 components critical to documentation. We'll go over each one. So evaluation is the resident's risk, includes a Braden or a Norton scale. The Braden is the most widely used, and it includes nutrition as a factor that the Norton scale does not include. NPUAP recommends that you use a risk assessment tool, whichever one you prefer. And we talked earlier about risk assessments. Make sure you document the tool you're using, the results, and any interventions to be implemented, and complete the risk evaluation per your facility policy. Next slide, please. So, using WoundRounds gives the facility the ability to complete the risk assessment and the interventions portion of the facility risk assessment portion of the pressure sore prevention and treatment program all in one place via 2 methods, either using a handheld device at the bedside or via the web. The risk assessment can be customized and preset to notify the facility and or the nurse when an assessment is due based on the facility's preferences. Risk assessments can be set off schedule for residents with a changing condition or returning from leave. WoundRounds notifies staff of due or overdue assessments with each login. The due date is also visible on the resident screen every time the nurse clicks on the resident's record. When state comes in your building and is asking for risk assessments, WoundRounds helps you create that risk assessment list for all residents or just specific residents, and that list can be printed. Documenting each resident's skin assessment provides a written description of any wounds or alterations for the resident. This is true whether on paper or electronically. And photos are just another piece of that assessment. These documented assessments prove you did your job, whether the pressure sore is improving, declining, or just maintaining. It gives you a measure to monitor and evaluate the progress of the pressure sore, the treatments, and the interventions used. These assessments are critical to your facility's risk management program. The beauty of the WoundRounds solution is that each facility can customize the interval for completing wound and/or skin assessments. And then WoundRounds lets your staff know upon login and one click what assessments are overdue for their assessments. The skin assessments in WoundRounds are comprehensive and complete. The accuracy of the assessments is duplicatable across all levels of your nursing staff. Help buttons are available throughout the assessment module to ensure staff are assessing wounds consistently and using the most up-to-date industry information. We've talked at length regarding documenting the interventions planned and implemented for each resident, whether they are quote, just at risk or have an actual pressure sore. So interventions can be added or deleted as appropriate with each update of the Braden or whenever a change it needs to be made. Ideally, when the risk assessment is completed, the intervention should be updated. The least amount it takes to update the interventions, if nothing has changed, is a click. Actually, it's 2 clicks. And then your residents' interventions are up to date. Nursing management can review if risk assessments are updated simply by clicking on their active census. Interventions can be reviewed by clicking on a specific resident's patient risk profile. WoundRounds will also generate a report that indicates the risk assessments subcategories for each resident, helping the facility to involve other departments in pressure sore care and prevention. When state comes into your building and is asking for risk assessments and/or interventions, a risk assessment list for all or just a specific resident can be printed. If interventions are wanted, a specific resident's risk assessment and intervention can be printed also. Individual goals. Interventions and treatments should have measurable goals, even if that means that the pressure sore won't heal. Sometimes just maintaining a pressure sore or even its inevitable decline is a goal. Just make sure all your supporting documentation is there. So how often does your dietitian see your residents who are at risk? CMS requires a facility to employ a qualified dietitian, either full-time, part-time, or on a consultant basis. If a facility does not have a full-time qualified dietitian, they must receive, quote, frequently scheduled consultation from a qualified dietitian. The intent of this regulation is to ensure that a qualified dietitian is utilized in planning, managing, and implementing dietary service activities in order to assure that residents receive adequate nutrition. This is especially true for residents with pressure sores. You need to check your state regulations for the exact timing of your dietitian consultant visits, because most state regulations will give you a specific time frame to follow. So make sure that all your dietary consultant recommendations are approved and initiated timely. Make sure the documentation is complete for each resident, especially those at risk. And be sure to include meal consumption and supplemental consumptions. With nutrition and wound rounds, interventions can be added or deleted as appropriate with each dietary consultant visit or when recommendations are made. Nursing management can review these interventions simply by clicking on a specific resident's patient risk profile and reviewing those interventions. Wound rounds will also generate a report that indicates the risk assessment subcategories for each resident, helping the facility to involve other departments in pressure sore care and prevention. Nutrition risk subscores can be sorted and printed to help the dietary consultant key in on specific residents at nutritional risk. Repositioning and support surfaces. This is such a big category. But the main thing is document what you're doing intervention-wise for your residents. It's not enough that you've identified it on the Braden list of interventions, or listed it in the care plan, or listed it in the electronic record for the CNAs. It has to be documented that it is actually being done. Don't list an intervention that you can't do, or sign off or prove that you are doing, or do as it's ordered, or as you're claiming that you're doing. Good documentation is your proof that repositioning and support surfaces are being completed as ordered. Next slide. With wound rounds, here again the interventions can be added, deleted, or deleted as appropriate with each support surface implementation. Nursing management can review these interventions. It will generate you a report, and the activity, mobility, and friction and shear risk subscores can be sorted and printed to help staff key in on specific residents, especially those who are at risk in areas where support surfacing can be utilized. This is excellent to use, especially for therapy with picking up Part B residents. Hemodynamics. Usually when we think hemodynamics, especially with pressure sores, we're thinking protein levels, total protein, albumins, pre-als. But broaden your thinking and think outside of that protein box. Does the blood pressure or cardiac medications have any negative implications regarding pressure sores? Absolutely. Perfusion is a key causal factor in the development of pressure sores, and it's a key factor in promoting the healing of the pressure sore. So think outside of just that protein box. Document what you're doing and the results. So how do you know what you're doing is working? You reassess and you reevaluate. If it's not working, you change it up. 14 days is the norm for reevaluation of treatments if no progress is noted. Consider using the push tool to help you evaluate if what you're doing is working. The push tool, for those of you not familiar with it, is a pressure ulcer scale for healing tool. It utilizes subscores from the length and width, exudate, and tissue type to generate a total score indicating healing. The lower the score, the better. Standards of practice. If you're not quite sure what to do, look it up. Use standards of care or practice guidelines to drive your wound healing in your building. CMS Wound Care Guidelines at 314 is the minimum requirement. There are lots of wound standards of care and practice. MPUAP is the most dominant. WOCN is also another excellent resource. Regardless of what your standard of care or the practice that you're referencing, document what you're doing. WoundRounds is designed to be a comprehensive wound risk and wound assessment management tool utilizing industry standards and federal regulations. So, you're reassessing at least weekly and reevaluating the wounds every 14 days for effective treatment. Does the same nurse do all of your assessments? If not, are all the nurses trained to do the assessments the same way? Do the nurses document that assessment the same way? Is it pre-programmed to ensure the same information is documented each time an assessment is done? Does your program prompt your nurses to capture data consistently each assessment? Or are they left to their own devices as to what they should document? How does your wound system management help you monitor the progress your residents' wounds are making? Does your wound management system, whether on paper or electronic, generate reports for you? Show you who is having a decline? Who is healing? Is your wound management system comprehensive to the point that all wounds are assessed consistently, documented consistently, and provide you with consistent report to improve your risk management program? So with WoundRounds, on a daily basis, you can check your risk assessments to ensure that all are completed timely, simply by clicking on the active senses and looking for the red. You can check your skin and wound assessments to ensure that all are completed timely by clicking on wound patients and look for red. You can check that all notes are completed timely according to your policy by clicking on the wound batch review. Spot check risk interventions to ensure they were updated with the risk assessment due that day. And spot check treatment interventions to ensure that they were updated with the wound assessments due that day. Remember, WoundRounds enables all your assessments to be consistent, and WoundRounds enables you to monitor your residents' progress. Weekly, you want to review a sample of your WoundRounds. You can do it weekly, bi-weekly, or monthly, whichever fits your schedule, paying special attention to wounds that are worsening and or static. Run a wound batch review and scroll through making sure wound status, clinical stage, and tissue types match appropriately. If they don't, this would be an opportunity for re-education with your staff. Review all stage 2s in your building. They should not have beefy granulation, slough, or necrotic tissue. You can run a wound report and sort by clinical stage, and then verify the tissue types by looking at the full assessment for those residents. If there are discrepancies in the assessment, this would be an opportunity for re-education with staff. Remind your NBS nurses to pay attention to the tissue alerts in section M0700 of the NBS worksheet. If an alert appears, a correction, change, or update needs to be made to the wound assessment. Review treatments to ensure listed treatments in wound rounds coincide with physician's orders and your TARs. Including treatments and keeping them up to date enables the MDS nurse to have the latest information. Become familiar with the oldest pressure injuries in your facility. Verify this documentation related to the inability to heal to ensure that it's adequate. And you can run that wound report and sort it by date identified will give you your oldest pressure injuries. I would suggest you run a wound exceptions report every 14 to 30 days and review any wounds that have been worsened by stage or by push score. Make sure that the family and the MD has been notified and that that notification has been documented. And is the reason for the decline been documented also? If there's been a change in condition or a change in the plan of care, make sure that's been documented. If you'll review your wound exception report every 14 to 30 days, that will give you a leg up on keeping your QM percentages low on your short and long stay measures. As a corporate nurse, when I had wound rounds in my building, I did these tasks daily, and I encourage my DONs to do the same. And I will have to say that after implementing wound rounds into our buildings and doing the above-mentioned monitoring, we never had a risk-associated or wound-associated deficiency cited. Next, we're going to talk about education. Wound rounds gives you several areas to document resident compliance and or non-compliance, both on the wound assessment annotation screen and also on the treatment notes. It's also a great place to document that initial teaching or any re-education opportunities with residents. Also available to each user after login is WoundRounds University. This section of the solution offers training videos with subjects including Braden's or risk assessments, wound assessments, and wound exception reports, to name a few. WoundRounds University also offers webinars covering various topics such as differentiating lower extremity wounds, wound assessment and documentation, wound staging, and more. I wanted to mention to all, before we get to our case study, about the release that came out mid-April from the NPUAP regarding the change in terminology from a pressure ulcer to a pressure injury and the updates in the stages of the pressure injuries. Hopefully all of y'all have gotten this information by now, but the term pressure injury will now replace pressure ulcer. The change in terminology more accurately describes pressure injuries to both intact and ulcerated skin. In the previous staging system, our stage 1 and deep tissue injuries described injured intact skin, while the other stages described open ulcers. This has led to confusion because the definitions for each of these stages refer to the injuries as pressure ulcers. Other changes, instead of using Roman numerals, we'll now use Arabic numbers, and the term suspected has been removed from deep tissue injury diagnostic label. We also have additional pressure injury definitions that include medical device related pressure injury and mucosal membrane pressure injury. So on this case study, this was actually one that occurred whenever I was a surveyor doing an initial tour, and I observed a resident to have multiple pressure sores and was not on any type of pressure redistribution or reducing device. The charge nurse stated at that time that the resident had a history of pressure sores and did currently have pressure sores. I looked, quote, under the covers at that time to observe the pressure sores. One area looked much newer than the others and was not receiving any treatment. The record review revealed no documentation for the newer area, indicating to me that it had not been assessed, and I couldn't find any treatment orders either. Although I did locate an order for the week previous for a low air loss mattress. So when the charge nurse and I went into the resident's room to observe and verify the pressure area and the lack of the pressure reducing device, the nurse stated, "I guess I should have put that mattress on when ordered, and then he wouldn't have gotten the new area." Of course, I had to document all of this, and it did result in an SQC and an IJ. So if the facility had a comprehensive risk management system, and the charge nurse or nursing administration was assessing the resident for risk, implementing appropriate and/or ordered interventions, if the CNAs were assessing skin daily, the nurses were assessing skin weekly, and ordered treatments for new areas were implemented timely, which should be the same shift, and then nursing management had monitored the assessments, the risk, the skin, the nutrition, the labs, monitored the interventions, monitored implementation of interventions, reviewed the treatments and orders, conducted bedside monitoring, and reviewed documentation of all of the above, the resident would have had a positive outcome instead of a negative outcome, and the SQC and IJ could have been avoided. So, working with the do's and don'ts of working with your state surveyors. Hopefully everybody's got a good working relationship with the surveyors that come into their buildings on a routine basis. That can go a long way in facilitating a good relationship with your surveyors, and some of the things that help facilitate a good relationship is be honest and forthcoming with the surveyor. If you don't know what the answer is, say you don't know, but that you'll find out. A surveyor hates to feel that they are being lied to, and quite honestly, it makes them want to dig a little deeper. Be prompt in providing information asked for. If they're waiting for requested items, then 9 times out of 10, they're going to be out on the floor looking at stuff. Have the best tool you can for risk and wound management, whether it's on paper or electronic. Personally, from being in the industry and on the surveyor side, WoundRounds is very comprehensive. It keeps current. If you utilize the tool, in this case WoundRounds, to its highest potential, your residents will have better outcomes, and the facility will likely have fewer deficiencies, citations, and/or litigations. Don't fabricate information. If you don't have it, say you don't have it. You may get a deficiency, but maybe it might be just a concern regarding the missing item, depending on how egregious it is. Don't wait and take your time getting the information to the surveyor. They're going to remember what they asked for and when they asked for it. And you certainly don't want to have that conversation with the surveyor or the regional office with the facility, quote, impeding the survey process. In summary, we've gone over a lot of information. Most you're probably aware of already, but if you follow the guidelines at F314, you are providing just the minimum care required for the resident. F314 talks about risk management. It talks about avoidable versus unavoidable pressure sores. It talks about prevention of pressure sores and the documentation of all you're doing for your residents. And it focuses on those residents who are already at risk and enter with pressure sores, and those who are at risk and then develop pressure sores because you, and/or the facility did not do what you should have done. Remember to always document, document, document. It's time well spent. Utilizing WoundRounds, even at a bare minimum, can help your facility maximize the nurse's time spent assessing risk and wounds and minimize their time spent on reports. We've got a couple of slides included with reference materials for you. I appreciate your time and your attention today. And Deb, I'll turn it back over to you.
Jamie, I wanted to thank you for a great presentation today. I think that we've all walked away with a much richer understanding of F314 and some really deep insights on what you as a surveyor have looked for that I think can help guide us as we work with surveyors in our future. I know that it is at the top of the hour and that probably several of our participants have to scoot and go on to other meetings. So what I'm going to do at this point is thank WoundRounds for making this possible and share Jamie's information here for any of you who might have some questions. Please feel free to follow up with Jamie with her contact information here. And you can expect from us that we'll be sending you once again a copy of the handouts, and we'll also be sending you an archived recording of today's webinar for you to reference this again in your future. Additionally, I know this information will also be posted in the WoundRounds University. So again, on behalf of WoundRounds, thank you so much for joining us today. Jamie Smith and myself, Deb Kurtz, we thank you for joining us, and we'll be signing off with you now. Hope everyone has a great day. Thank you.